about 11,000 US dollar at the most in India. Again, in Egypt, we're talking about 75,000 Egyptian pounds, which is almost within the same range. It's about 10,000 after the devaluation. It's still a very cheap procedure. And again, I don't know the cutoff when to apply and when not to apply the transplant, because you could never tell those who can be well taken care of, well chelated, and well followed, and with a high quality blood transfusion, and those who are going to get into complications. Bone marrow transplant, if it works, and it works very nicely. And I can say that when you apply it, even in the higher risk group, as you can see in my cohort of patients, we're talking about almost 80% were belonging to risk class 2 and older age group and high iron load, and yet you're having a disease-free survival of almost 75% for the total number of patients.
Excuse me again, I'm sorry. Because I am transplanter also, I should be biased, but
I am biased.
Oh yes. But according to your very nice lecture, we have transplanted 150 patients with thalassemia over 15 years. 10 patients per year. Is it fair or not? This is what I am trying to do. Shall we go ahead and establish a lot of cases? Yes, this is what I am saying.
Only one center.
Yes. Shall we establish a very huge number of centers nationwide, or shall we start?
I cannot agree more, and I can tell you that we had when you're having more experience, you're supposed to get even better results. Actually, our results are still, as we're getting higher risk classes of patients now, even much more than before, and our disease-free survival is a bit less than what we used to report earlier. Definitely, you need more centers to accommodate the numbers, because our waiting list, and definitely thalassemia in a big transplantation center is not on the top of the list. You're having aplastic and anemias and leukemias. We might consider a transplant in a much urgent way. But what I want to say, and we have to commend to try to prevent thalassemia from happening. We shall accommodate more patients.
This is a very important point, Dr. Ala. I would like to ask you, serum ferritin is one of the deciding factors in the outcome of bone marrow transplantation. Why don't lower down the serum ferritin for all patients before stem cell transplantation in order to improve the outcome of their necrosis?
Earlier, I think we shared some information because I needed to update our results, and we collected all the patients, those who received bone marrow and everybody was included in the study, and it's for the first time that we have seen such a difference, and probably we have to take care of, as I said, aggressive deletion before putting the patient into the transplant. But sometimes, definitely, you could never tell whether it was working or not, and how much time you need to get the patient into a negative iron balance. It's not an easy thing, I believe.
My name is Ahmed Darwish. I'm also an assistant teacher from Missouri University. I just want to ask a question about cord blood transplantation in patients with thalassemia. This is number one. And number two, the minimum age for a patient with thalassemia to receive bone marrow transplantation, thalassemia patient. And do we have any experience for cord blood transplantation here in Egypt? Because many mothers ask us about, I want to donate, I'm just pregnant, and I want to donate my baby's cord blood for my coming, or for my thalassemia baby. This is number one. So, can I advise her to donate her cord blood here in Egypt, especially? I would like to. Thank you.
I think I will answer first and then Robert. But this is a sort of a matter of opinion. I will give you my opinion. In my personal view, cord blood for thalassemia doesn't have a lot of usefulness. The reason is that either you have a compatible sibling, so the mother with a child with thalassemia now gets pregnant, has another child, prenatal diagnosis is done, maybe also HLA typing, and you know that the newborn will be HLA compatible. So the dilemma is, shall I collect cord blood or shall I use the bone marrow when, to answer your second question, the child is in the proper age to donate bone marrow, which is anywhere between 6 months and a year. Even a 1-year-old can donate bone marrow. Now we all know that cord blood is a sort of a more fragile graft and also is more expensive. So in general, the attitude, at least in the centers in Italy, and there are again different opinions, but has been to not use the cord blood, but use, because thalassemia is a chronic disease, it's not like leukemia, you have to rush to bone marrow transplantation, but wait until the newborn is 1 year old and get the bone marrow. Sometimes a combination has been used, so you collect the cord blood and then again you wait 1 year and you combine frozen cord blood with fresh bone marrow. For unrelated transplantation, my personal view is that it's not going to have a bright future in thalassemia, because now you have to really confront with very effective chelation. So if you propose bone marrow, you have to propose it when you're sure that you get at least a 90% success. This is how I see it, because otherwise it's not competitive with aggressive chelation. That's why I completely agree that now you should try to downstage, to decrease ferritin, to decrease iron overload before you bring the patient to transplant, because you should really minimize mortality and morbidity to be, ethically appropriate in comparison to very effective chelation.
I cannot agree more. I'm not a fan of cord blood HLA related cord blood transplant in the setup of Beta Philippines. And again, it's about time, and you can wait like 6 months or 1 year, and then you can do the transplant. And this is exactly what I used to advise the patients when they are referred for a transplant. This is regarding your first part. Our experience in doing cord blood transplant, we did quite few number of patients related cord blood transplant, and for me, I can announce today that we did our very first successful unrelated cord transplant for an HLH case, but he has to get the cord unit, and it was from New York cord blood bank for what is equivalent to $60,000 US. So the family got a unit for $60,000, and we managed to do a transplant that was successful. It's now about the plus 90s, but early to judge the things and going very smoothly. But unrelated cord blood transplant is very costly, especially if you're lacking an HLA identical sibling. We're having the know-how, but we have to have our own, at least, cord blood bank. For other indications, I believe that if you're not having the awareness and we don't have a registry of our own, regional registry, and we are not represented in the international registry, then it's much more economic and easy to have your own national cord blood bank. I believe it's a must.
Questions, then thank you all the speakers and the audience, and close the session. It's a coffee break, and please be there here at 1:50 exactly, 10 minutes before 2. Okay? الدكتورة ريسيرش كتير عامله اوريجينال ميديسن وايه قول لنا ريسيرش عن اوريجينال ميديسن. اتفضلي حضرتك.
السلام عليكم. أول حاجة بشكر المايسين كوميتي مايك الأمان الشلاوي organizing committee, Professor Dr. Amal Bishlewi, chairpersons, Professor Dr. Sumay Golay, Professor Dr. Mehmet Ansari, Professor Samia Riz. My talk today will be about regenerative medicine basic principles. Regenerative medicine is a multidisciplinary field concerned with repair, replacement, or regeneration of cells, tissues, or organs to restore impaired function. The human body has an endogenous system of repair and regeneration through stem cells found in all body tissues. Regenerative biology seeks to understand the cellular and molecular differences between regenerating and non-regenerating tissues, while regenerative medicine seeks to apply these understanding to restore tissue structure and function in damaged non-regenerating tissues. Regenerative medicine encompasses a spectrum of technologies and approaches ranging from cell, biomaterial, and drug therapy for promotion of endogenous regenerative capacity to whole organ and tissue replacement with laboratory-grown organs or biomimetics. This is how FDA views the world of regenerative medicine as cells, biomaterials, and factors, human tissues, stimulators of endogenous repair, xenotransplantation, biologic device, combination products, gene therapy, and lastly, cellular therapy. Cellular therapy is the use of stem cells in regenerative medicine. Stem cells are defined as cells capable of proliferation, differentiation, and self-renewal. The first logical use of bone marrow stem cells was in hematological disorders. Bone marrow transplantation for hematological and non-hematological malignancies began on the concept of homing. Observations after bone marrow transplantation paved the way for two most interesting concepts in stem cell biology: plasticity and homing and extended homing. Plasticity or transdifferentiation means the conversion of cells from one differentiated type to another, or the ability of lineage-specific stem cells to cross lineage boundaries and adopt the molecular pattern of a different lineage. These are some examples of transdifferentiation. Bone marrow stem cells normally differentiate to hematopoietic cells, but can transdifferentiate into hepatocytes, bile duct epithelial cells, myocytes, neurons, astrocytes, and oligodendrocytes. Talking about plasticity, it's observations following gender mismatched transplants of bone marrow transplant patients. They found donor-specific mature cells. They found donor-specific hepatocytes, donor-specific cardiomyocytes, donor-specific renal cells. That means that the infused hematopoietic stem cells infused intravenously differentiated into these tissue-specific cells. The theory of homing was that when I inject stem cells intravenously, they will circulate and move and home into the bone marrow because it's their original home. The extended homing of the theory is that stem cells have the function of regeneration also in extra bone marrow tissues, so they can home to damaged tissues even if outside the bone marrow. So observations following bone marrow transplantation for multiple myeloma patients proved the regenerative effect of infused hematopoietic stem cells on the kidneys. So infused hematopoietic stem cells home to the bone marrow and to the kidneys because they were damaged, and they regenerated both here and in the kidneys. Also, the observations of increased circulating hematopoietic stem cells during myocardial infarction and its relation to prognosis, the more circulating hematopoietic stem cells were found in myocardial infarction, the better the prognosis was found, meant that probably they have a role in tissue regeneration in myocardial infarction. All these concepts gave rise to the concept of regenerative power of stem cells or the role of stem cells in normal repair. When talking about stem cells for regenerative medicine, we have to talk about the choice of the source of stem cells, choice of the method of isolation, choosing the method of administration, method of evaluation of the experiment, and cell tracking. So choosing the source of stem cells, we can get stem cells for regenerative medicine from the bone marrow, which is the original source, peripheral blood after mobilization of bone marrow stem cells, mature cells using the induced pluripotent cell technology, adipose tissues, and the cord blood Wharton jelly or amniotic fluid. So using the bone marrow has some advantages and disadvantages. The advantages of bone marrow derived stem cells is that more efficient stem cells with high telomerase activity, higher plasticity, and they are cheap to get. The disadvantages is the low frequency of the CD34 positive hematopoietic stem cells or the mesenchymal stem cells, the painful procedure, and the lifespan decreases with age. Using peripheral blood as a source of stem cells after mobilization with BCSF or other mobilizing agents, we can get a large number of stem cells. They have high frequency. They are active cycling cells, which is an advantage and disadvantage. The disadvantage is that because they are active and cycling, they have lower telomerase activity, probably low reduced lifespan, and the higher cost because we add the cost of mobilization and leukapheresis. When we get to the cord blood stem cells, we can get cord blood stem cells from the cord blood itself, the Wharton jelly, or the placenta or amniotic fluid. They're available, non-invasive, and cheap. However, we have to have public banks or banks for HLA to get the HLA matching cells. They are immature cells with probably lower plasticity. The adipose tissue derived stem cells. It's non-invasive, larger quantities, but there's still much research documenting the function. It's not finished yet. The induced pluripotent stem cells are mature cells that have been genetically reprogrammed to an embryonic stem cell-like state through ectopic introduction of transcription factor genes critical for maintaining the properties of embryonic stem cells. This allows the generation of patient and disease-specific tissues for targeted disease research. This is the ideal, but it's still in the research era. Choice of the method of isolation of stem cells. Choice of stem cell separation method had to be taken in 2 steps. The type of selection, is it positive selection or negative selection, and then the technique of selection. So the type of selection is that targeting the cells that I want, or do I target the cells that I don't want to get a pure population. So we do selection if we need to remove a certain cell population, we need to remove antibody or antigen presenting cells, or if we are injecting in a very limited space, so we need a limited cell number, so we only inject the needed cell number, like injecting in the eye or in the testis. Do we do selection or no selection? The advantages for selection is that we can use a very small number of cells, because these are the wanted cells, and we can reduce it into a very small volume. However, it's expensive. And another thing is that these unwanted cells may be an important function of stem cells. Probably they may provide angiogenesis, may provide paracrine action, like trophic factors. The last thing is that selection involves more manipulation, so it may compromise sterilization and viability of the cells. So this is positive selection. We target the wanted cell, the desired cell, the cell in yellow. So it's used when the presence of the bound antibody is not a concern, high purities are required, and numerous antibodies are required for the depletion. These are not available. Negative selection, here we don't target the desired cell, we target unwanted cells, and we take the desired cell by exclusion. This is preferred when the binding of the antibody to the directed cell may result in blocking or activation of downstream studies, or when a specific antibody to the cell of interest is not available, or if we need to eliminate a specific cell type. Choosing the method of selection, we have different methods of selection. We have physical, which is non-specific depending on the size, density, or other physical properties like plastic adherence. Culture method depends on plastic adherence, like separation of mesenchymal stem cells, or combined physical and culture, like more nuclear cell separation, then culture and tissue culture flasks for plastic adherence. And then immunological, which is specific depending on the pathogenic properties of the cell, which is either the immunological is either FACS sorting or immunomagnetic bead separation. method of administration of the cells after separation. We can use the stem cells as injectable cells, as separate cells, or in a cell polymer mix. It's less invasive. It adopts the shape of the environment, and we can use controlled growth factor release. Or we can put the stem cells on a solid scaffold manufacture, whether computer-aided design or to match the shape effect or choosing a method of evaluation. This is the clinical part of the regenerative medicine, so I'm not going to talk about it. In vivo tracking is to verify the in vivo ability and function of the cells, to assess the in vivo homing and migration, to assess the presence or absence of transdifferentiation, and to document the presence of injected cells. I have to know the cells I injected, whether they functioned or not. So we can use marker chromosome detection. We can use Y chromosome gender mismatch or human centromere and xenogenic transplantation. We can use green fluorescent protein transfection of the cells before injection, but this is in animal experiments, of course. It's not allowed in human. And it's iron oxide labeling, which is the only approved study for human use. We can label the cells by iron oxide particles, and then either detected by MRI imaging or by tissue biopsy and staining for iron. The top 10 regenerative medicine applications for improving healthcare in developing countries are proposed to be the islet cell replacement, cardiac muscle, immune modulation for infectious diseases, tissue-engineered skin substitutes, biocompatible blood components, cord blood banking, tissue-engineered cartilage, stem cell-mediated gene therapy for inherited blood disorders, nerve regeneration technologies, and hepatocytes for liver cell failure. طبعا يعني احنا لما دي موجوده بره لو احنا هنتكلم هنخلي hepatocytes for liver cell failure يمكن اول حاجه. So future directions in regenerative medicine, we have to standardize the central cell processing facility protocol. We have to improve antimicrobial methods. We have to overcome the allergies. If synthetic biology is used with natural materials made synthetically or economically, cell implantation on decellularized natural tissue. Donated organs are decellularized. This is a step after cellular therapy, which is the use of decellularized organs as a natural scaffold for stem cell therapy. So donated organs are decellularized in order to render the implant immune compatible, avoiding the need for immunosuppressive therapy, and resulting in a the resulting complex natural scaffold is then repopulated by the patient's own cells, thereby producing an autologous tissue engineered organ زي ما عملوا في التركية من سنتين. In the light of the growing shortage of donor organs, regenerative medicine and tissue engineering technologies are poised to have a tremendous impact on extending both the quality and duration of patients' lives. Thank you.
Thank you, Dr. Hala, for your very comprehensive overview on regenerative medicine. And now it's open for discussion.
الديوريشن بتاعت الستام سيل بتبقى قد ايه؟ ولو في حاجه السؤال التاني لو هي حاجه اوتو اميونولوجيكال الريكورنس انها تحصل تاني بعد ما يعملوا ستام سيل ثيرابي.
هو حكايه الديوريشن دي قصدي حضرتك الفايبيليتي بيفور انجكشن ولا it's
after injection after injection viability
after injection دي varies from a condition to the other. In liver cell failure, because the microenvironment is cirrhotic liver and probably the blood supply is not enough, maybe the cells don't live for long. But if the microenvironment is good, like in accidents and for nerve injury or something, the lifespan is better. So it's condition related. It's not absolute.
يعني it needs only one procedure ولا ممكن تبقى repeated procedure الانجكشن ده يبقى repeated؟
المفروض ان احنا يعني المفروض انك تعمليه once. بس امتى هتحتاجي تعمليه repetition if any فيها اصلا cannot accept the desired number of cells at once. بس ممكن space it, or if you can't get the cells at once زي ما بتعملي بوست يمكن ما تقدريش تجيبيهم كلهم مره واحده.
طب والحاجات الاوتو ايميولوجيك اللي هي اوتو ايميولوجيك هل ممكن يزيد ريكارنت تاني على اساس ان الستابس برضه بيحصلها اوتو ايميولوجيك بروسس؟
والله انا ما اشتغلتش في الاوتو ميون، بس انا بشوف الكلينيكال ترايلز بره بيعملوا الاول ميون سبريشن زي ما يكونوا هيعملوا زي البوم ترانسبلانتيشن، بيعملوا يعني ريسيتنج النيو سيستم الاول before injection of the new stem cells.
Thank you.
المايك يا سامية، المايك يا سامية.
How to ensure the purity of the culture, several sub-cultures, how to ensure the purity in the structures. If there's a way to know that,
Whether we need to know that or not depends on the source of the cells. If the cells are autologous, and I'm injecting a bone marrow autologous bone marrow stem cells differentiated into hepatocytes, for example, and if the differentiation efficiency was about 50%, so I'm injecting 50% hepatogenic cells and 50% bone marrow cells from the patient. So I don't need to have a pure population. I need to have a pure population if it's allogenic.
no problem. I'm honestly, in culture, cells are having a trans-differentiation potential. The majority will probably differentiate to the line, usually active while the broad-spectrums are added. But there are at least some cells will not follow this direction. Can we ensure that they didn't differentiate to another type, another line?
We can, but we can do that, but I don't think it's routine in the. All we do before injection of the cells to the patient is safety, antimicrobial safety, plasma bacterial culture, and chromogenic assay to ensure that they are not carcinogenic or
Any more questions? Yes?
For the blood stem cells, like HLA1, any other rejection, how to overcome?
If you use for the blood stem cells, to know if that cell is safe or not. So will undergo rejection if blood. How to overcome this problem?
I didn't get the question. You mean that they don't express HLA1 on the surface?
I don't understand, but mesenchymal stem cells, they are not immunogenic, and you can give even allogenic mesenchymal stem cells with no rejection record. But the hematopoietic stem cells, you have to make HLA typing, and it's better to have at least, I think, 6/6 compatibility for successful transfer of stem hematopoietic stem cells.
Second.
No more questions? Thank you again, Dr. Hela.
And now, Dr. Azza Saleh Edwan. She is a professor of clinical and chemical pathology at the Heart Institute, and she is a certified international trainer of research ethics from Maryland, USA, and she is at the Egyptian Network of Research Ethics Committee coordinator, which is the emirate, and also she is an ambassador of Mapping African Research Ethics Office. Dr. Azza.
Thank you. Thank you very much, Dr. Sumaya. I'm very honored to be here in your conference, and I'm thankful to Professor Amal Zishlawi and of course to Professor Mervat Ansari and my dear friend Sami. My presentation will be different from all what you heard in the morning except of that of Oreo, because it will be about the ethics. I hope you will enjoy, and you got the message. I'm fond of puzzles. Usually I'm starting my presentation with a puzzle which is not done. At the end, hoping I will reset this part. The outline or the overview of the talk, we will just mention a few words about vulnerability and the thalassemia. Then we'll talk about the ethical requirements and the take-home message at the end of the presentation. Are thalassemia patients vulnerable? This is a question I'm posing. Do you think that they are vulnerable? But first of all, we have to define what's vulnerable. What's vulnerability? Vulnerable, we have different definitions, but I just captured only two: capable of being wounded, susceptible to wounds, or open to attack. They are easily attacked. In Arabic, we are saying it as al-fi'a al-mustad'afa. Another definition, according to science is one of the international guidelines which are present for ethics internationally. Their definition is are those who are relatively or absolutely incapable of protecting their own interests. This is the definition of vulnerability. More formally, they may have insufficient power, intelligence, education, resources, or strength, or other needed attributes to protect their own interests. This is the definition according to science. What are the types of vulnerability? We have different types. It may be cognitive or communicative, and this applies mainly for children, for our case in the conference. So the first kind of vulnerability the thalassemia patient had is that they are children. This is first. They may be institutional prisoners, students, or employees. Maybe economic. They are dependent. They are poor people. Social, like minorities in some countries, and these minorities also apply for who are not speaking the language, non-English speakers. Usually they are minorities. And medical, serious health conditions, they are considered as one of the 5 types of vulnerability. So I think now we can answer the question, are thalassemia patients vulnerable? Yes, in my opinion they are, because they are, most of them, they are children, and the second, they are in a serious medical condition. According to the international, the science I mentioned, they have the guideline 13, they have several guidelines. Guideline number 13, there are 21 guidelines. The guideline number 13, they are emphasizing on the vulnerable individual, and they see that their rights and welfare must be strictly applied. Also, the Declaration of Helsinki, this is another one of the international guidelines. They mentioned that doing the research on vulnerable group has to only be justified if the research is related to their health needs. And this is very important, and also it is applicable for the thalassemia. Now, if I ask you, what makes research ethical in general? I think somebody will say having informed consent, or REC approval, we got the ethics committee approval, we are compliant with the international guidelines, we are compliant with the legal regulations, or maybe all of the above. This is true, but to put it systematically, to have the research ethical, we need to fulfill 8 ethical requirements. And this is the main issue we will talk about during the coming 15 minutes. Community partnership, social value, scientific validity, fair subject selection, favorable risk-benefit ratio, independent review, informed consent, and we have to respect the enrolled subjects in our clinical trials or our studies. Community partnership. Please, to be ethical, clinical research must involve the community in which it occurs. And we have to keep in mind also always that research are done with the community, and we are not doing the research on the community. In Arabic, احنا بنعمل الابحاث معاكم مش عليكم. يا ريت نبطل نستعمل لفظ احنا بنعمل الابحاث على المرضى بتوعنا. It's not fair to say it, and it's not common. Community participate in all phases of research. We have to do this. What is the benefit of having the community partnership? You will respect the culture of the community you are doing the research with them. You will increase your acceptability. You will be giving fairness and equity, and you will gain having information exchange if you do the research, and put in mind that community partnership is very important. Always, teamwork makes the dream work. Let us do the research with the community in the concept that we are a teamwork, trying to get a result for our community. The second item is a social factor. The experiment according to the Nuremberg rule, this is the third type of international guidelines I mentioned in my presentation, and this, they mentioned that to be ethical, the research has to be for the good of the society. And this is another thing which is very important. To be ethical, clinical research must lead to improvement of the health of the subject, first, the participant of the research, and also significant generalizable knowledge to be mentioned or to be published. We must consider the participant in the research and the community with which research is conducted. The third thing is scientific validity. To be ethical, research must have a valid, practically feasible method, has to have clear scientific objective, well-designed, accepted principles, adequate numbers. Neither small number is ethical and nor large number is ethical. Both of them are unethical. Sample size is very important for the research to be ethical. And the data analysis plan has to be very well organized. In other words, it has to be a systematic protocol has to be present before doing the clinical trial. So, if we are following all this, the result will answer the original research questions you are putting from the beginning. You may have a scientifically significant good question, but you conduct the research in very bad method, you will get invalid results, which is unethical. The reverse, study is unethical if methods not feasible, poor measures, you don't have the suitable sample size, statistical analysis were very poor, and we were biased, or you will not report your results. Why unethical? Because it will be waste of resources, waste of time, and exploitation for the participant of the research we do. Together, everyone achieves more. This is the teamwork we have to follow also while doing a scientific research. The fourth thing is fair subject selection. Fair subject selection is very important, and it implies for the inclusion and the exclusion criteria. The practical, how to practicize having fair subject selection is by putting inclusion and exclusion criteria in your research. This is very important. The sample size or the patient or the participant in your research has to be put according or selected according to the purpose of the research, and not because they are convenient, they are less able to protect themselves, or they are available. And this is very bad. In other words, it's not fair to do research on such kind of children for the benefit of these children. This is really unfair. On the reverse, you should not select rich, politically powerful, or otherwise well-connected people for promising research. The reverse, the story from the other side. Always inclusion and exclusion criteria are the main items we have to follow while choosing our participants. Fair subject selection is following the principle of justice, because in research ethics or while doing research ethics we have three important principles. The first or one of them is the justice. So fair subject selection is the practical or the applicable way of doing justice in research. The fifth thing, this is very important. Do a double blind. Do you think this is fair? Do double blind, give the new drug to a rich patient and a placebo to the poor. No sense getting their hopes up. They couldn't afford it even if it works. I think this is completely unfair. The fifth thing is favorable risk-benefit ratio. To be ethical, the potential risk needs to be minimized, the potential benefits to be enhanced, and the potential benefit has to be outweigh or more than the potential risk. The risk has to be identified, and this is very important, according to several things. Not only physical risk, but we have to look at the physical risk, of course, the psychological risk, the social risk, and the economic risk. These are all types of risk we have to look at while measuring the risk. Again, the risk has to be evaluated regarding the magnitude and likelihood. Risk has to be minimized by applying the best design during putting the protocol of your research. Potential benefits has to be enhanced as much as we can. If the potential benefit to the individual is more than the risk, proceed, go ahead, no problem. You don't need to think about it. If the risk is more to the individual, then you have to evaluate according to the social benefit or the knowledge gain, but still you have to be sure that the participant will be subjected to minimal risk, not more than minimal risk. The favorable benefit risk ratio is the application of the second principle, which is the beneficence. The first, justice, beneficence, and you will see that the third will be also mentioned. The sixth item is independent review. Independent review is the meaning that you have to follow or to subject or to submit and have an approval of the ethics committee. Why? Because usually all the researchers, why they do research? They do research for the advancement of science, for promotion of careers, for enhancing reputations, for obtaining funds, for protection, of course, of right and welfare of the human subject. They take care, but all of us, we have our angel and our angel. Conflicting obligations might lead even well-intentioned investigators to fail to notice the proper protection of human subjects included in the research. That's why we need to have this independent review balances with the possibility of competing interest with the protection of human subjects. And this is the role of the Research Ethics Committee. And please don't think about it, let's have fun, let's go to gross out the Ethics Committee, because all the time people are thinking that the Ethics Committee is not a friend. I'm swearing that Ethics Committee usually it's a friend committee, it's trying to do the best. The seventh item is informed consent, and in Arabic, الموافقة المستنيرة أو الموافقة المبنية على المعرفة. Usually in Egypt we are using الموافقة المستنيرة. What is the informed consent? And this is very important. We have to know that the informed consent, it's not a piece of paper. مش حتة ورقة the participant will sign. It's a process documented by a form. And this is very important to keep in mind. By which a subject voluntarily confirms his or her willingness to participate in a particular research after having been informed of all aspects of the research. And this is important and very important for the informed consent. The informed consent should be concerned about the competence of the subject. The subject has to be competent and has to understand the information you are giving. And at the same time, you have to disclose a good amount of information. You have to be sure that the subject understands the information you give, and the voluntariness of the decision is very important. Excuse me for the foreigners, but this I have to mention in Arabic because this is our constitution. دستور جمهورية مصر العربية ده على فكرة الدستور اللي قلنا عليه نعم. المادة 41 موجودة فيه. الدستور القديم كان فيه نفس المادة بس كانت مادة 43 وما كانتش مطولة كده، لأن دي يمكن تعمل لنا شوية I hope ده ما تعمل لناش مشاكل، لأن حكاية الموثق دي يعني في التطبيق هتبقى صعبة شوية أو ممكن تعمل مشاكل، لأنه we can have waiver of the document for the informed consent, and we can have waiver of the informed consent itself. So mentioning here that it has to be موثق, I think it will cause some. Let us see how this will be done in the future. The guidelines which require usually several items to be present in the informed consent. There are 8 essential elements has to be present, which are the purpose and the duration of the participation, the risk, the alternative, the benefit, the confidentiality of the record, the compensation for injury, the person to contact for answering questions, who I have to contact if I am a participant in a research when I need to ask a question, and voluntariness and the right to withdrawal are very important to be met. These 8 items has to be are the essential elements of the informed consent. There are other 6 optional elements. If you want to put them, it's okay. Otherwise, these 8 are enough. And important things that the informed consent is the application of the third principle, which is the respect for person. Informed consent for research has to be approved from the ethics committee. This is very important. You have to submit a template of the informed consent you will use during your research, and the ethics committee has to revise this informed consent, and they have to stamp it and approve that this is the informed consent you will be using through the whole research. The eighth item is the respect for enrolled subjects, means that you have to continue respecting your participant. It's not the issue of signing an informed consent and be enrolled, you stop respecting them. This is very important. You have to respect the permission, you have to give them the permission to withdraw. You have to protect their confidentiality all through the research. You have to inform them if there is something newly discovered, and monitoring all the time the welfare of your subject, and you have to inform them at the end of what was learned from your study. How to protect seriously ill subjects, how to protect our thalassemia patients. Regarding the consent, because most of the patients, as much as I know, are children, you have to get an assent. Consent is regarding the parents. The parents have to consent, but the child has to give assent. Assent in Arabic we are saying rida. The child has to give assent. The language of the informed consent has to be understandable by the participants. And in general, we are saying in Egypt that the language of the informed consent be to the level of الأعداد عشان يقدروا يفهموها. Otherwise, we have to get, if the parents are not available, you have to get the permission or the consent of the LAR, which is the legally authorized representative. You have to state clearly the potential of risk and benefit. It's better to have a third party to perform or to have the informed consent or do the procedure or the process of informed consent, and the auditors has to be present in such research, including seriously ill subjects. The other thing, apart from the consent, potential subject should not be approached immediately after diagnosis. Immediately after diagnosis, it's not nice to men, not nice, it's not human to ask them to be enrolled in a research while they just know that their diagnosis. Also, the same thing apply when they learn that the standard treatment present failed, and so you want them to be included in clinical trial for a new treatment. You have to independently monitor the seriously ill during this research. You have to limit the level of risk, and we mentioned that this has better to be done, or the best way to do this is by having the best design, and you have to limit the payment incentives not to attract them by money. And this is not, we call this undue inducement. You are trying to attract them by giving them a lot of money to allow them to enter in your study, which is above minimal risk or risky study. The 8 ethical requirements are universal, although they must be adapted to the health, economic, cultural, and legal requirements in which clinical research is conducted. This is a snapshot of the 8 ethical requirements with the definition in front of each of them. They are arranged chronologically also. The take-home message is that research is necessary for the advancement of knowledge, for science and treatments of disease. So, and human subjects are absolutely essential to accomplish this task. And if I ask the present who is accepting to be a participant in a clinical trial? Yes. Subject in a clinical trial. I see three hands up. 3 hands, 4, 5, 6, 7. To be participant in a clinical trial. It's great. So still, these people are who accept to participate in clinical trial, they deserve the highest standard, which can be ensured by following and applying the principle and the ethical requirement when conducting research. And the fulfillment of requirement in chronological order ensures that research has value, that the research do not exploit the participant. Participants are treated fairly with respect, and their interests are protected. My puzzle, I was told that the way of progress was neither swift nor easy, because I'm fond of married men. And thank you for your attention.
Thank you very much for the very specific lecture. I would like to know if there is a certain age in which children can consent for meeting a study. I'd like to know if already you have an agreed upon age that children can consent for meeting the clinical study.
Usually the children, you have to assent. Well, you are asking about the consent.
Yes.
The consent for signing. Okay. We have to, usually we discuss this with a lot of people, but some people are saying that 18 is a good age or a suitable age for signing. But in my opinion, and in some of my friends, that 21 is the best age for signing, because before 21, the people cannot sell their house, sell their car. So it's logic not to sell their body parts. So I think 21 is the best age, but I don't. Thalassemia, do you have another opinion, or you agree on 21?
This is based on the legal, the informed consent is a legally binding document. So legally you are responsible for what you are doing at the age of 21. This is in Egypt, because in other parts of 18. But the age to be considered as a children, as a child, universally is 15.
18 universally, but in Egypt I think it's 21.
Allow me to make a comment about this, because the legal age is different from one country to another. And doing research, clinical research on children is a debate. Right? So you have to have the consent of the legal guardian if the child is not reaching the legal age according to the country. This is different from one country to the other. The assent is something else. The assent is that you explain to the child what is going through. And the assent form, there are many forms of assent forms according to the age of the children. You can have assent forms in drawings if the children cannot read. You can have assent forms in a simple language for the children. You can have an assent form in a more advanced language for a higher age. The assent is something else, because the child cannot decide whether, because usually, as our presenter said, the research is done for the progress of science. And it is for the parent to decide whether he's going to enroll his children or not. The benefit of whether they are taking drugs or something, this is something else. But the child has to understand and has the right to withdraw if she doesn't want to continue in the clinical research. So it is a debate, because according to the Nuremberg Code, at the very beginning, children were not allowed to participate in clinical research whatsoever. It was condemned to do clinical research on children. But the process has changed, because there are diseases which are peculiar to the pediatric age. There are drugs which are used only in the pediatric age. For example, the surfactant. So the pharmacokinetics, pharmacodynamics are different in pediatric age. So it is legal to do pediatric research, and the concept has changed from protecting children from research to protecting children through research. So it is ethical to do clinical research, but to abide by the rules, by the ethical rules of pediatric clinical research. According to the little incentives, it's not allowed to give them any financial incentives. The incentives are limited to the accommodation, transportation.
This is it's compensation. Compensation for traveling, compensation for the accommodation if they will stay 2 or 3 days. You have to afford this.
You mentioned that the consent, the documentation of the consent form may not be documented or maybe even waived. Can you elaborate on that?
In which conditions? Sometimes you cannot prove the research while asking for a consent. For example, if you are doing observational or you are just watching, or in some of the psychiatry, you are looking at what the reaction. If I tell you that I will have consent, I'm observing you, the research will not be done. So it's usually it is waived. Whenever the research cannot be done with the consent, and something important also, it is usually waived when, or we can waive it, so long that it's minimal risk. It's below minimal risk. Watching is a minimal risk. Although it's a breach of confidentiality or breach of your privacy, but still it's minimal risk.
Just to waiving the informed consent is not the decision of the researcher. It's the decision of the committee. And the other thing about pediatric research, even if the parents are okay with volunteering for research on their child, if the child is doesn't agree for that, or didn't give an assent, or refuse to do that, he cannot be forced to do it. Yeah. Parents' approval doesn't mean that he has to do that.
مش هنكتفه يعني مش هنكتفه يعني لازم هو يبقى فيه اسنتات يرضى. Just want to add also, because the waiver of the informed consent and also some of the research can be exempt from being we have to submit, all types of research has to be submitted. Most all type of research has to be submitted to the Research Ethics Committee, and they will decide if it's possible to waive the consent, and if it can be exempt from follow-up. But it's not the decision of the researcher, as Professor Samia mentioned.
Some rights may be done to study the reserve, some rights may be done to study feasibility.
Study the
about the feasibility. Those big that the maneuver must be visible. But some studies, some trials may study the feasibility of a certain recipe. حضرتك الشروط ممكن لازم يبقى المنوفر اللي هنعمله يكون يمكن اجراءه، يكون فيه فيزابيلتي، لكن بعض الرسائل او بعض الدراسات بتبحث الفيزابيلتي نفسها اذا كان ده ممكن اجراءه ولا لا. فازاي احنا هنعمل
Can you give me an example of such research?
جراحه مثلا هنعمل في جراحه عمليه معينه هتتعمل بسنتج بورت في المنظار. هنعمل جراحه بالمنظار بدل ما نعملها من 3 بورتس هنعملها ببورت واحد. فده لما بيتعمل اول ما ابتدى من سنين قريبه يعني كان في رسائل كتير. الرساله بتاعت شخصيا في المناظير كان فيها جزء خاص بدراسه امكانيه اجراء جراحي معين بالمنظار. امكانيه اجراءه ده كان موضوع رسائل. فازاي يبقى من شروط من الايثكس ان يبقى الاجراء فيزبل بالبرفورمانس ستاف. شكرا.
هقول لحضرتك it's very difficult if you want to check the feasibility from where you got the experience. So there is some papers or some publications. You got the idea from publications or you invent from yourself. في حاجات بتبقى اثبتت ان ده اتجربت قبل كده ولا حضرتك بتجربها على طول، وفي تجارب بتتعمل الاول على الحيوانات. في تجارب اتعملت قبل ما نوصل ان احنا نعمل على البني ادمين.
لغايه وقت التجربه ما كانش اكسبتبل ستاتستيكالي احصائيا، ما كانش مقبوله احصائيا. لسه لغايه دلوقتي مش عارفين اذا كانت هي الريزولت بتاعتها اوكي او لا.
وحضرتك عملتها؟
بالنسبه لنا هو
هقول لحضرتك حاجه في حاجه اسمها في الكلينيكال ترايل في فيزز ومن ضمنها الديفايسز، تمام؟ ففيز 1 ده احنا ما بنعملوش في مصر. يعني ما تقلقوا ان احنا بالقانون ان احنا نعمل فيز 1 في مصر. انا بس بتكلم بالعربي علشان ده حاجه خلينا معروفه، احنا ما نقدرش نعمل فيز 1 في مصر. فمعرفش ان حضرتك عملته ده، عملته على كم مريض؟
لا حضرتك اشتغلنا على 20 عيان في انواع من العيانين نفسهم، يعني نوع في انواع كتير من السبب، في انواع كتير يعني تفصيلات يعني ده كلاسيفيكيشن ففي نوع اصلا منهم كان تركيب الشبكه فيه بطريقه معينه اصلا مش بتر، فتغيير الطريقه برضه طلع مش بتر في عين واحد اللي هو ايه بنفس الطريقه.
هقول لحضرتك هو تقريبا حضرتك يعني كنت بتحاول تعمله ده تقريبا بوصف حضرتك كده انك بتعمل على عدد قليل وتجربه جديده خالص ما اتعملتش، ده الحقيقه فيز 1 والمفروض ان فيز 1 ما بيتعملش في مصر لان احنا ده لو بريكوشنز مش موجوده عندنا واخد بال حضرتك، فعاده يعني لو حضرتك كنت رحت اللجنه الاخلاقيات ما كانتش هتوافق، فعشان كده بقول لحضرتك عملت كام عيان وعملتهم يعني ربنا ستر يعني لان هو مش المفروض ان احنا نعمل على عيانين اي تجربه بتطلع في المنهج، ففي فيزز بتمر ولازم ان احنا نجرب على عدد قليل قوي.
هو مفيش ضرر بالنسبه للعيان غير ان الموضوع يكون الفرد نفسه رجع اول
لا مفيش ضرر ازاي؟ يعني لو حضرتك الطريقه بتاعت المنظار ما نفعتش كنت هتعملها بقى عمليه عاديه القديمه.
عملناها عاديه.
العمليه القديمه. يعني هو الريسك اللي حضرتك عرضته ليه هيبقى الريسك بتاع الانستيزيا والريسك بتاع اللي حضرتك اشتغلت عليه وقعدت تحاول فيه وكان لازم يبقى عارف يعني قصه طويله شويه. اتفضلي دكتوره نادية.
Thank you, Professor Azza, for this excellent presentation. But I just wanted to ask you about the importance of attendance of a third party or auditors, the consent process. I don't understand what is meant by this third party.
Third party, usually we have a witness in the informed consent. The informed consent, the one who will sign, the child, and a third party, the witness.
Why?
The witness.
Why witness if
we need a witness, even if he is understanding and he can sign, a witness to be sure that the informed consent process has been done. The process itself has been done.
The witness is usually used when the patient is illiterate or blind or some
no
country.
But in some, it's better to have a third person, especially for the vulnerable groups, a third party unrelated to the study. Unrelated to the study.
Yes, yes.
Not from academia.
What about the auditors? You said
the auditors and monitors, they are auditing every now and then. They are not attending the informed consent, but later on they are auditing the informed consent. The witness is present the day as any informed consent. They have to audit the informed consent in the clinical trial.
Can I ask a question related to the question of my previous colleague? If this surgeon had the approval of his local research ethics committee and has a well-constructed informed consent and a good consent process, could this research be ethical?
It could be ethical if all the precautions are taken, if the patient knows what will be done, and the alternatives are present. The alternatives were mentioned in the informed consent, that if this new technique failed, what is the alternative? And if he refused, what is the alternative? And if he refused to have this experiment or this trial, the alternative is that. But this has to be mentioned in the informed consent. And usually the ethics committee approve to have at least 5 cases or 1 to 3 cases and come back, because this is more than minimal risk, and they give the approval for less than 1 year, not for 1 year as usual.
Thank you.
Thank you, everybody. This is the last question.
Just a comment. Thank you very much for the presentation. My comment is all the rules that put here and on the ethical committees and so they are based on something that is not usually, not always present, which is unconditional access to the most appropriate and the new modality of treatment. Our patients here are vulnerable and are more vulnerable because they do not have access to the most advanced treatment modalities. This part is not covered by any law, but it's only covered by our soul. So I just still recommend I have to say.
Just I will add something, Dr. Khalid. If you are trying to use an advanced technique, you have to divide. The best way is to do double blind or double arm study, and the other arm, the arm for the new treatment, and arm for the standard treatment present. And the standard is the standard universal standard and not the standard English. And if you will try a new technique on some patients, you have to get another group. This second group has to take the standard of care. And standard of care is the universal standard of care, not the standard of care in our country.
There is some debate about which one to consider the standard of care. For example, if they don't have the money essentially to do this kind of care, you should search for other alternatives. So what you call, if you're going to do the setting as is, as my standard, this is called pragmatic study, and it is possible to do. You want to try your own circumstances as it is in comparing patients using two different types of drugs. Well, this is a special type of exception to that. This is a special type. You want to know with your circumstances and your standards, using two different and only change the treatments, what is the success rate with that versus that maybe you improve your standards more. But I mean, if you apply this in an absolute way, then some countries would not have, in countries which do not have access to any advanced care, you would probably would not be able to do any clinical trials. Thank you very much. Thank you very much, and now we can come to closure, and thank you everybody. Thank you, Dr. Azza. Thank you.
The third session will be on thalassemia and sickle cell disease associated morbidities. It's my honor and the pleasure to have Professor Dr. Yusri Abdulrahman and Dr. Sheikh, together with Dr. Hamdi Ghazal, will be in the session, sharing this session. Actually, because Dr. Sheikh has got a date outside, is going to start this talk. Professor Dr. Sheikh is a professor, an eminent professor in thalassemia in Tanta University. He's going to talk about infection and immunity in thalassemia.
هو أصلا المفروض كان المفروض يشتغل بس كانت واحد يوم بس هو عشان بقول لك ورانا
بسم الله الرحمن الرحيم. My subject is today infections and immunity in thalassemia. Actually, infections is considered the very important complications and the very commonest cause of death in thalassemia. It's considered second cause of death and the complications in thalassemia and the hemodialysis in general. Morbidity and mortality rate of infection throughout the world depend on many factors, mainly the epidemiology and the infection and socioeconomic standards, and the protocol and the strategy of treatment for each patient, and the presence or absence of complications of iron overload. Factors affecting infection, direct exposure to infection risk, and the large spectrum of immunological abnormalities, nutritional deficiencies, especially zinc deficiency and iron overload, besides the other therapeutic modalities and the options as recurrent blood transfusion and splenectomy, central venous catheter, and bone marrow transplantation. Immunological abnormalities in thalassemia, the patients with thalassemia is considered as immunocompromised patient in neglected cases, but when the patient is treated under specific protocol and routine strict blood transfusion and chelations, is not considered as immunocompromised. On the other hand, the alterations in the immune system due to iron overload play an important role in the infection. The immune alterations include change in the ratio of CD4 and CD8. CD4 the reported decrease, and CD8 increase, especially in aspiria with splenectomized patients. Phagocytic function, cytokines interleukin 4 and 6 and 10, they increased. Also C3 and C4 complement and immunoglobulin changes, and neutrophil chemotaxis and the natural killer also disturbed. Order of the monocytes macrophage, they become the erythroid precursors, occupy the upper hand for phagocytosis. For the case of hemolysis, the phagocytic activity is increased against the erythrocyte precursors and the erythrocyte in the hemolysis. This effect on the defense action against pathogenic microorganisms. The alteration in cytokines increase all cytokines, elevate and suppress humoral and cellular mediated immunity, and increase infectious risk. Immunoglobulins not significantly changes, especially Ig and IgA and IgG, but IgM be decreased, especially in symptomized patient. Risk related to iron overload. Actually, the iron overload play a very major role in the changes in the immunity. Damage the disequilibrium between oxidation and the effectiveness availability of these symptoms, and to counteract oxidative stress. Also, in addition to antioxidant system, the retin and the monocyte macrophage compartment also participate in clearing up toxic iron. Also, the lysosomes in this macrophage also affected by increased iron towards the protection from iron, and the additional oxidative stress can destabilize the secondary lysosome in macrophage, and the protective role is lost. Also, the phagocytes of neutrophil also affected. This is the figure shows the imbalance between oxidant and antioxidants. The oxidants of iron overload is more whatever the antioxidants as ferritin synthesis and antioxidant enzymes and antioxidant vitamins, in addition to monocyte macrophage compartment, direct uptake by lysosome and autophagocytic of ferritin and apoferritin from the lysosome. Common infection associated with iron overload. Gram-negative organisms are the major cause of infection in thalassemia, especially Klebsiella species, Escherichia coli, Yersinia enterocolytica, Pseudomonas, Legionella, Vibrio strains, and so on. This statement, very, very important statement, most of these bacteria increase its virulence by the use of chelation. How the chelation increase the bacterial virulence and increase severity of the This will be discussed in the next few slides. The iron is essential growth factors for bacterial growth and multiplication. This is well known. The bacteria uses the iron for multiplication and growth. The bacteria acquire and produce releasing of high affinity chelators called the siderophores. These siderophores will take the ferric iron through the bacterial receptors, special bacterial receptors will go in the iron inside the bacteria and multiply and increase virulence. This is, only for remember, deferoxamine vertispiral is a bacterial, natural bacterial siderophore obtaining from streptomyces, as we know, and these iron-chelating agents used in thalassemia is very dangerous when, especially for bacteria not produced endogenous siderophore. This summarizes the mechanism of bacteria use iron. Bacteria release siderophore, endogenous siderophore, with siderophores with ferric iron complex through the special bacterial receptors will go in the bacteria and multiply and increase virulence. With the exception of the Yersinia enteropolitica, the special entity, the Yersinia enteropolitica is not produced endogenous siderophore. عشان كده لما بتدي اكسوجينوس siderophore اللي هو الديسفوركسامين بيبقى بيدخل الايرون inside the cells. Systemic Yersinia infection occurs almost exclusively in patients with iron overload treated with chelating agents which act as exogenous siderophore. انما في الهيومن، في النورمال هيومن تيشو اليرسينيا بتبقى ريستريكتد لان مفيش فيه ايرون ولا فيه siderophore. البيتا ثالاسيميا patient with Yersinia infection represent 5,000-fold greater than general population. فرق كبير جدا بالنسبه للجيري. The prospective study performed repeatedly for frequency of Yersinia enteropolitica infection in 10% of thalassemia patients per year. Every year, 10% of thalassemic patients affected by Yersinia. This is a CT scanning for a case of GIT infection by Yersinia. Showed the narrowing of the lumen and the necrotic lymph nodes present in the terminal ileum and ileocecal valve, presented by severe diarrhea and vomiting, severe abdominal pain, diagnosed wrongly as appendicitis, as acute abdominal pain with severe septicemia and systemic infection. Now the question, have all creators have the same effect on Yersinia enteropolitica? This is the question. In the comparative study between deferoxamine and the deferoxamine desferal على virulence and growth of Yersinia show synthetic iron chelators belonging to the synthetic iron chelator or deferoprone مش natural chelators زي deferoxamine show have no effect on the Yersinia growth and enhancing effect after 3 hours incubation in experimental work. Deferoprone may thus represent a useful alternative iron chelation. في حالات الثلاسيميا اللي بيستعملوا اسفرال ومتعرضين ل او suspected of Yersinia enteropolitica الالترناتيف بتاعنا هو السنسيتيك اللي هو الاورال ديليشن اللي هو L1 is the best. These figures shows the difference between deferoxamine and deferoprone L1 in different concentration and with comparison with the organisms colonies according to the duration. We show the deferoxamine with dotted and the control have significant differences with the change of the doses and the duration by use of desferal, while in deferoprone, no significant difference between both. Another comparative study between deferoxamine with deferopron L1 in comparison with deferoxamine 3 comparison, no on the growth of other variants of thermophilic organisms زي الفيبريا والفيبريوسترينز واليرسينيا. هنلاقي ان الكلينيكال results بتاعتنا لما عملوا discs filter paper impregnated in each of deferoxamine, deferoxorex, and deferopron, the organisms and the colonies around this filter paper impregnated in these chelators, the least is the oral, the deferoxorex and L1 in the green. But the desferal or deferoxamine is the very dangerous in the Yersinia and all the ferrophilic organisms. Risk related to allogenic blood transfusion, the other risk, اللي هو زي ما الفيروس اللي هي blood borne diseases, hepatitis B and C, human immune deficiency virus HIV, CMV, and parvovirus B19, which is caused a plastic crisis in such cases. The incidence of hepatitis C in our Thalassemia Center in Tanta University is about 40% of cases. This is in the study and published. Risk related to splenectomy is well known, and the splenectomized patient is considered as immunocompromised patient due to defect of the immunoglobulins and chemotaxis, also macrophage. The most common bacterial infection in splenectomized patients is encapsulated pathogens, as we know, especially streptococcal pneumonia, Haemophilus influenza, and Listeria meningitis. The streptococcal pneumonia accounting for more than 75. This is the most common pneumococcal. Other gram-negative organisms have also been implicated. Now we are going to the few slides, guideline for management of infections and septicemia in thalassemia. The patient of thalassemia will reach to temperature above 38.5 degrees centigrade or systemically unwell is very critical to put in the emergency, and the emergency treatment must be done. Many different investigations will be done at first: full blood picture, renal function, kidney function test, and blood glucose, blood culture, stool culture in case of diarrhea, suspected Yersinia infection, urine microscopic and culture indicated serum viral serology, and the swab for everything, and the culture and the stool culture. Empirical treatment of fever and sepsis in children, treatment should be urgent within 1 hour. The patient with fever, piperacillin and tozanidectin, 90 mg per kg for 4 days, gentamicin 7 mg per kg once daily, check level per 3 doses, vancomycin in case of central line, vancomycin. The empirical regimen is the same irrespective of the previous antibiotic courses unless there are known antibiotic resistance. The Nilurinab can be used in case of suspected meningitis. Treatment if there is diarrhea and vomiting, then the ciprofloxacin is the drug of choice for gastrointestinal symptoms in 6 mg intravenous every 8 hours in case of the suspected Yersinia after stool culture. If the patient is sensitive or there is a contraindication for use of ciprofloxacin, we can use co-amoxiclav instead of ciprofloxacin. In general, and this is a statement and message for you, for all, in general, all chelation therapy should be stopped, discontinued, until the child has fully recovered. Start once fever, once infection, the all chelation must be stopped, and thank you.
Thank you very much. Dr. Shepard, for your very interesting presentation. Is there any question from Dr. Shepard? This is going to leave. Okay.
I want to ask you also that 40%.
Thank you, Dr. Shepard, for your talk. But I want to ask, you said that there is 40% infection or 40% cases after the blood transfusion each infection. Which type of blood transfusion you give? You give the double strength or the double check blood transfusion for them, and in spite of that it's 40%?
Yes. Yes. In spite of check all the blood donors in the blood bank against the commonest virus, virus C and virus B, we found the incidence of hepatitis C reached to about 40%. 40% hepatitis C. I don't know the Professor Dr. Yanis how he discussed hepatitis C. I don't know what is the percentage in Cairo. This. This? High. Ah, yes, more than 40%. I don't know why. Any other question? Double check, yes. Double check in the blood bank. The main job for the blood bankers.
Any question? Okay, if there are no questions, thank you very much.
Thank you very much.
Next speaker, Professor Dr. Lamis Rakat. Dr. Lamis is the ex-dean of Faculty of Medicine at Cairo University, and she's an international figure in hematology and in medical education. Dr. Lamis is going to address hepatitis C and thalassemia, two interrelated Egyptian community problems. Please, Dr. Lamis.
Good afternoon, ladies and gentlemen. Thank you very much, Professor Bishlay, for the introduction. I'm going to talk about hepatitis C and thalassemia, two interrelated Egyptian community problems. As most of you know, that we are working at the hematology department at the Faculty of Medicine, Cairo University since 1981, so we have more than 30 years of experience at pediatric hematology. And before I talk, I would like to extend my thanks to Professor Amani Bishlawi, which introduced the whole team to the international level and started to do clinical research and clinical trials, which they did not do before that. And the team of physicians at the hematology department, the team of nurses, the labs of the pediatric hospitals, of the 3 pediatric hospitals, because we cannot work without the lab people, and most of all to the patients at our clinic. The outline of my talk will be hepatic dysfunction and thalassemia, some results of clinical studies at the hematology department, measures for prediction, prevention, and protection, and I will focus on the role of intrafamilial transmission of hepatitis C, which is the last work we have done at the clinic. The number of newborn thalassemic patients has reduced all over the world, but unfortunately at our clinic it is rising, and this was 2003, but now we have more than 30,000 thalassemia patients at the clinic. The magnitude of the problem of hepatitis C is not only in Egypt, but it is worldwide. So nearly 4 million persons in the United States are infected, 35,000 new cases are discovered every year, and most of them become chronic, and it is the leading cause of chronic liver disease, of cirrhosis, of liver cancer, and is the most important indication for liver transplantation in the US. And these numbers show the magnitude of the problem worldwide, in Africa, in the Americas, in Southeast Asia, in Europe, in the Eastern Mediterranean, and the Western Pacific. So it's not only a local problem, but it is a universal global problem. And mind you, that they don't talk about public health anymore. Everybody talks about global health, because within a few hours with the aeroplane, we can transmit a disease from one part of the world to another part very easily. But unfortunately, Egypt has the highest prevalence of hepatitis C infection in the world, averaging 12 to 24% in the general population. And we all know that the prevalent type, which